Игорь Александрович, тогда, возможно, вы представите следующего докладчика?
Да, конечно.
Спасибо большое.
Dear colleagues, I want to introduce our next speaker, Dr. Petr Krupa. He's a neurosurgeon from Czech Republic, and he's a researcher. He focusing on few aspects in neurosurgery as well as in research, and one of them is a spinal cord injury. I had the pleasure to meet him here at my clinic, and we spent a few months of very active work on a few projects here. So he probably will cover some of those details what we did here at my clinic. And I just want to say that I was really impressed meeting Peter, because his capacity to kind of connect things in his field. So I'm not sure if I can explain this, but Peter, please correct me. I remember when I asked you why you were interested in spinal cord injury, because it's kind of not the most critical part of neurosurgery, right? Your explanation was that you focus on two things, brain tumor, right? Yeah. And spinal cord injury. And for me, it was hard to understand how you connect those things. And you explain it's very simple, because those two things at this moment almost impossible to treat, right? And it's kind of a challenge that you see as a researcher, as a neurosurgeon. And it was very interesting for me to kind of learn like, your approach to set up challenges and follow these possible solutions. And again, thank you so much for joining us today. And please, yeah.
Thank you, Igor. Good afternoon, ladies and gentlemen. Do you hear me? It's okay, everything okay? Igor?
Yeah, it's good.
Okay. Okay. Greetings from Czech Republic. My name is Petr Krupa, and I work, as Igor said, as a neurosurgeon in the University Hospital Hradec, Kralove. So first, thank you, Igor, for inviting me to this emerging seminar. It's really an honor. And my talk, which will be much more from the field of the experimental medicine than the previous clinical ones, will be related to functional reorganization of the central nervous system after the spinal cord injury. And finally, it will introduce the concept of the translesional network. So very briefly, everyone knows spinal cord injury can be classified according to AIS into the incomplete spinal cord injury and complete spinal cord injury. And probably for most of us, much more important is that even with clinical diagnosis of complete absence of voluntary control after spinal cord injury, the majority of these injuries contain residual subfunctional connections, more or less capable of transmitting supraspinal commands to the spinal cord circuitry below the injury, which is classified as the discomplete injury. Most of the treating effort, next to the treating spasticity or bladder functions, is focused on restoration of the movement, and what's even more important, restoration of the volitional movement. This inevitably requires the restoration of the connectivity, which is linked with changes and reorganization of the supra and sublesional circuitry. There is a lot of treatment strategies, mainly in the experimental medicine, which are more or less effective, including stem cells, scaffolds, hydrogels, or anti-inflammatory compounds. And of course, for us nowadays, the most promising clinical therapy is the epidural or electrical stimulation. So now let's focus and discuss changes leading to reorganization of the functions after the injury, which occur in all levels of the central nervous system. So let's begin with the cortical plasticity. After the injury, there are confirmed significant changes in the superficial cerebral cortex, as well as in deep structures of the brain. We have recent, but also previously published clinical papers which proved anatomical changes using the magnetic resonance imaging study. We also have some functional studies, the functional MRI or EEG activity, which confirmed that the level of the blood oxygen is increased in the contralateral primary motor cortex and is associated with the severity of the patients. And the EEG studies confirmed that there are changes in the alpha, beta, and theta activity. However, these changes are still have to be elucidated, and we nowadays don't know exactly what they mean. So the cortical plasticity means that there are changes in both motor and sensory cortex, which are leading to reorganization of movement representation, expansion of uninjured areas, with the functional shift toward the unlesioned side. And this inevitably leads to reactivation of brain plasticity. This is usually linked with the dendritic remodeling and sinus formation. By the way, there's a very nice article related to this. Also, there is a new protein synthesis and synaptic efficacy. All of these changes can be enhanced by various treatment strategies. For us is the most important intensive rehabilitation programs. After electric stimulation, it is also confirmed that the serotonin administration or the brain-derived neurotrophic factor. Now let's move deeper in the brain, into the brainstem. It has been shown that critical role in control of locomotion in vertebrates in brainstem plays so-called MLR, the mesencephalic locomotor region. This is an interesting topic, and we can talk about it very long, but very briefly, MLR is comprised mostly of mesodiencephalic DA cells, which are modulated by the DA system of the basal ganglia. There are two main routes through which DA pathways converge with the MLR: the classical ascending pathway, where DA cells project to basal ganglia with subsequent projection to the MLR, and also an alternative, the descending pathway, which constitute direct innervation of MLR from substantia nigra pars compacta and zona incerta. It comprises cholinergic, GABAergic, and glutanergic neurons. And what's important for us, MLR stimulation, the deep brain stimulation elicits locomotion in decerebrated rats and cats. So nowadays it's mainly the experimental design. When we move more forward into the spinal cord, we can talk about the long track plasticity. It has been shown that important bypass routes for transmitting of the supraspinal commands are reticulospinal, cerebrospinal, and propriospinal tracts, which can bypass the signals from the damaged corticospinal tract. So let's focus on the reticulospinal system. It originates in the reticular formation of the brainstem, and their axons terminate mainly in the intermediate gray matter and ventral horn of the spinal cord. They are making connections with commissural neurons, the proprial interneurons, and motor neurons. The connections with the interneurons, they contribute to the spinal and potential lumbar CPGs, and as they collaterals at many levels, they contribute to interlimb coordination. There are papers from Cerner and May, which confirm sprouting and newly developed connections between reticulospinal neurons and axons and propriospinal neurons after the experimental hemisection model of the spinal cord injury. Cerebrospinal system neurons originate in the red nucleus, and what's important, they are making direct monosynaptic connections with spinal motor neurons. If there is a lesion in the red nucleus, there is a compensation for the corticospinal tract, and vice versa. When there is a damage to the corticospinal tract, there is a compensation on the corticocerebrospinal part. Also, the same as the previous one, there are confirmed sprouting and bypassing routes from the corticospinal tract to the cerebrospinal system. Propriospinal system, Dr. Lavrov once said, it's a dark matter. It's a system of interneurons which is contributing to modulation and tailoring of the motor commands. In uninjured spinal cord, the subsets of so-called V2 interneurons are coordinating and maintaining locomotor rhythmicity, while V1 interneurons have primary inhibitory function and are shaping the spinal motor output. Their tracts can be divided into long descending and short descending tracts. And there's evidence that short descending tracts have far better regeneration potential than the long descending tracts. It is also proved from the paper of Anderson and his group after the experimental transection of the spinal cord that the short tracts were able to regenerate through the injury site at least 5 millimeters long. Now let's move to our region of interest, the supralegional plasticity. Still little knowledge is available about these changes right above the lesion, but what we know is that there are presynaptic and postsynaptic changes, and there is a compensatory sprouting and rewiring. There are also 2 important papers which give us some insight into this area. First is from 2017 from Manohar, who studied corticospinal tract sprouting in various levels above the injury, and he found that the sprouting is highest in the lesion proximity, just above the lesion. And also the previously mentioned paper from Anderson. We can summarize that compared to other spinal neurons, neurons directly above the lesion could be influenced to a greater extent by afferent and afferent information for circuit reorganization and plastic changes following spinal cord injury. Let's move forward to sublesional plasticity. There are also circuitry changes and changes in a spinal cord excitability. And we can state that sensory feedback is a key factor, and that's why we accomplish in our rehabilitation programs rehabilitation and also the epidural stimulation, which stimulates mainly proprioceptive and cutaneous afferents of the dorsal roots. When we put supralegional and sublesional plasticity together, we can move forward to translesional plasticity. The main question of regeneration of corticospinal tract is still very debatable, highly debatable, and probably regeneration through the lesion site is still not achieved. But we know that there is a variable regrowth of the fibers through the lesion site and in experimental medicine through the scaffold. There is an important paper from the Maya group who found that the regeneration potential of the ascending fibers is far better than the descending ones. Which is important for our translesional network conception. This is not only one paper which confirmed that. There is quite a few other papers which are related to this topic. So finally, we are getting to a merit of this presentation, the translesional network. The presented evidence got us more precisely. We showed that sprouting is the highest above the injury. The short propriospinal axons have better regenerating potential, and higher numbers of ascending versus descending newly regenerative fibers across the scaffold suggests that ascending translesional fibers stimulated by epidural stimulation may influence the spinal circuitry above the spinal cord injury. The supralegional network subsequently could modulate and fine-tune descending signaling and transmit descending commands. This is the summarized picture, which what we think it might happen after the spinal cord injury. The A represents the unlesioned spinal cord when the motor control is driven by information from the motor cortex and the brainstem areas and modulated by somatosensory and proprioceptive inputs. Following spinal cord injury, most of the long descending tracts are disrupted with minimal number of spared fibers, which are not capable to transmit effective supraspinal commands to the sublesional network. Following spinal cord injury, following chronic reorganization after the spinal cord injury, regrowth of the ascending and descending fibers across the lesion facilitates information carrying by ascending sensory fibers to supralesional network, and together with the descending ones from the brain and brainstem promote reorganization of the sublesional and supralesional circuitry. And finally, sub and supralesional circuitry may be facilitated by electric stimulation, further engage communication between descending and ascending fibers, and functional connectivity via short proprioceptive propriospinal axons, which carry the information received by newly formed detour pathways from cerebrospinal or reticulospinal tracts. This translesional network is still quite a new concept, which is not highly tested, but there is a recent work from the Lavrov group who experimentally combined supra and sublesional epidural electrical stimulation in a minipex, and they used the bi-level stimulation in C5 and L2, which is above the lesion and below the lesion, and they find a positive effect, but there is missing a comparison to sublesional stimulation alone. This is a conceptual diagram. We talked about it in a first presentation that multiple stimulations may be beneficial for the patient. We can brain stimulation or the peripheral stimulation together with the sublesional and supralesional electrical stimulation. So finally, we can conclude that reorganization of the network after spinal cord injury is critical. Epidural stimulation addresses sublesional and supralesional network in this complete injury. Of course, we don't know much yet, so stimulation parameters have to be tailored, and the effect of the combination of stimulations have to be elucidated. Thank you very much. And Igor, maybe you may add something if you want.
Thank you so much. I appreciate this fantastic talk. It's quite a new question about translesional network and multi-site stimulation also, right? And I think it was discussed in many groups about potential of this approach. Yeah, so thank you a lot for this talk, and colleagues, please, if you have questions, please ask. Maybe I can start discussion just to ask your thoughts on potential clinical implication, like from your standpoint, from what you are doing. You mentioned that there are multi-level from cortex all the way down to peripheral nerves to combine neuromodulation, right? To some extent, it was combined, like paired source stimulation, right? But what do you think about next steps?
I think it was discussed in the first presentation. I think the easiest way to combine is the transdermal stimulation and epidural stimulation, because still the brain stimulation together with the epidural stimulation would be far much invasive. So I think next steps should be the combination of the transdermal stimulation above the lesion, for example, and epidural stimulation with the sublesional circuitry, but I don't know.
Actually, your talk also emphasized another key point, that we can have deal with two questions. One, activating of circuitry, right, CPG, and improving motor control with functionally silent fibers. And second question about connectivity, which could be the same or can be improved and improved by different ways, by regeneration versus by local sprouting, plasticity, and this likely will happen based on those short pathways across the injury, right? So not so many actually data in human subjects we can bring to discuss this point, right? But I wonder, like, your thoughts on difference between effect of transdermal stimulation, which is more relevant to control of posture, right? And epidural stimulation looks like more effective to control volitional movements. And with epidural stimulation, I think overall we can, again, maybe I'm wrong, but based on multiple findings, I think we can say that there is definitely immediate effect when you start stimulation after implantation. It's regardless how many years after injury, right? Those patients able to initiate some movements, but those usually more rhythmic movements, right? Like they trying to imagine themselves running or walking, and it's give them chance to kind of send this drive to initiate some CPG activity below the injury, right? But then over months of training with epidural stimulation, they regain capacity to more precisely control different joints. So likely we have deal with two different actions, right? More like neuromodulation effect versus long-term effect on circuitry, on plasticity. So do you think those findings in human subjects could be relevant to what you presented today?
I'm sorry, I didn't catch the question.
Yeah, so I'm trying to come with some examples from clinical trials, which could support your idea about translesional network, about potential targeting circuitry, which is changing over time when we use stimulation, right? And at this moment, we believe that this is primary circuitry below the injury, right? And except few animal studies, there is no data on supralegional changes. Right?
I think definitely is something happening supralesion, and I think that our concept makes sense. So it's hard to say right now because there are no data, but I believe that probably the stimulation above the injury could activate this circuitry and could facilitate the volitional control, but it still has to be elucidated. And maybe I'm not. We have a few numbers of these clinical subjects, so maybe someone from Kazan would like to add something about it.
Yeah, absolutely. Thank you. Thank you. Colleagues, again, please, if you have any questions, it's a good time to ask. Peter, and maybe a final question from my end. So from clinical perspectives, from your vision in neurosurgery field, how do you feel about this direction, and where do you think the next step, and what will be your next target?
In a spinal cord stimulation. It's hard to say because I think we are still at the beginning and tailoring the epidural stimulation below the injury alone. So I think we first have to have more data, at least in our country, about the sublisional network. And then when we understand precisely what's happening and how to work with a simple one level stimulation, we can add another one, but it requires time and few more trials, I think.
Thank you.